Parkinson's disease is a progressive neurodegenerative movement disorder caused by a loss of dopaminergic neurons in the substantia nigra. You'll recall that the cardinal symptoms we talked about are tremor, bradykinesia, rigidity, and postural instability. The symptoms can be controlled primarily by increasing the net effect of dopamine in the CNS. There are several ways that we can try to accomplish this. First, we can add dopamine agonists at the receptor. Second, we can increase the amount of dopamine in the CNS. Third, we can decrease the breakdown of dopamine. Now, this fourth method is a bit tricky, so we're going to refer back to the earlier first aid fact about the neuroanatomy of Parkinson's. Dopaminergic neurons normally inhibit acetylcholine release from the striatum. In Parkinson's, these neurons are lost, so there is an increase in muscarinic activity. Benztropine is an anti-muscarinic drug with CNS penetrance, so it is efficacious in Parkinson's. It improves the tremor and rigidity, however it does not improve bradykinesia. Now keep in mind that in a prompt describing a patient with tremor, it may not always be Parkinson's disease. For a question, you want to look for the other signs of Parkinson's. Essential tremors and familial tremors are usually isolated and not associated with bradykinesia or gait abnormalities, and for those tremors, non-selective beta blockers are the drug of choice. The combination drug of levodopa and carbidopa is the most effective treatment we have for Parkinson's disease. L-dopa is a dopamine analog. It's an oral agent, so it's absorbed through the GI tract, and it has to enter the brain through the bloodstream. However, L-dopa itself is readily metabolized by peripheral tissues. So, in order to increase its availability to the brain, it is administered with carbidopa. Carbidopa inhibits the enzyme aromatic L-amino acid decarboxylase, which converts L-dopa to dopamine, which does not have an ability to cross the blood-brain barrier. Carbidopa itself does not cross the blood-brain barrier, so only L-dopa is delivered to the brain, crosses the barrier, and is converted within the brain to dopamine. The side effects are mainly GI upset and possible arrhythmias. Now, it's important to know that this drug combination is for symptomatic management only. It does not have an effect on the course of disease. In fact, as the disease progresses, the duration of therapeutic activity gained from each dose decreases. This is termed the wearing-off effect, and it usually starts after 3 to 5 years of levodopa-carbidopa therapy. The dose of levodopa will improve mobility for maybe 1 or 2 hours, but then the rigidity and akinesia will return, and in later stages of disease, patients have what's often referred to as an on-off phenomenon. This means that they rapidly fluctuate between being off, where the medications aren't helping at all, and then being on, where the medication is helping, but they also have disabling dyskinesias. In addition, patients frequently will develop dystonias. It's an extremely difficult disease to treat. Selegiline is a drug that is used also for Parkinson's disease. In the brain, dopamine is broken down by MAO enzymes to inactive metabolites. Selegiline inhibits the MAO-B enzyme, which thereby increases the effect of dopamine. Note that this is different from the MAO inhibitors used to treat depression, which act primarily on norepinephrine and serotonin. Selegiline has been shown to enhance the clinical response to L-dopa, so it's used as adjunctive therapy. When it's used alone, there's only modest effect on symptom relief. Side effects from this drug include nausea as well as orthostatic hypotension. Alzheimer's disease is also a neurodegenerative disorder. NMDA excitability is known to cause brain damage and is thought to be some part of the pathogenesis of AD. Memantine is one of the drugs used to treat Alzheimer's, and it is actually an NMDA antagonist. The most pronounced degeneration occurs in the acetylcholine projections to the cerebral cortex in Alzheimer's. This is the rationale for using acetylcholinesterase inhibitors. Donepezil is the most widely used of the 3 available drugs. The drugs are generally quite safe, but unfortunately they are not all that effective. They don't change the course of disease, and in some patients they may slow the progression, so they end up being widely used. Huntington's is a genetic disease, and at this point only symptomatic treatment is available. No drugs can slow the progression of disease. Not all patients with Huntington's disease need to be treated. Only when the movement disorder is so bad that it causes danger to the patient or to others, such as falls or injury, should drug therapy be considered. As you know, it is caused by loss of striatal nuclei and therefore a loss of inhibition in the CNS. Tetrabenazine and reserpine delete dopamine in the CNS, so they may be helpful. When you prescribe these drugs, you want to monitor for hypotension and depression. Also used is haloperidol, or Haldol, which is a typical antipsychotic that blocks the dopaminergic receptor in the nigrostriatal pathways. Lastly, we'll mention sumatriptan. This is a very effective drug used for acute migraines. It's a serotonin 1B1D agonist and is available as a nasal spray as well as in pill form. Remember to be careful using this drug in older patients with coronary artery disease because it can induce vasospasm. That's all for neurology. Thanks for your attention.